Greetings of the day. So we'll wait for some more time so that everybody can join in. So before that, I'll just make you all to go through a video. Let me know if you can hear now.
Hospitals work round the clock to serve patients. Being at the center of the action, hospital physicians and staff must confront every situation and every challenge. They must also keep up with evolving health needs and knowledge through ongoing comprehensive training programs. What they need is a promising solution to ensure a continuous learning journey.
In today's world, technology is transforming life. Be it taxis, food delivery, everything we need is at our fingertips. Education is also going through a transformation, and we are at the forefront in the healthcare industry.
MedLearn is a comprehensive learning, training and skill development platform incubated at Impulsys in India for healthcare professionals to attain the right mix of content, learning and skills that help them throughout their career. The platform offers a wide variety of courses that enable hospitals to meet their employee training and development needs in areas of quality compliance, soft skills and induction. The platform is designed in a way that it enables easy tracking of the real-time status of their learning progress. What's unique about this platform is that it's accessible anytime, anywhere, ensuring quality learning literally at your fingertips. Hospitals can now assign courses and track the competencies of users on specific topics with MedLearn's intelligent assessment tool, which gives them better administrative control. Its superior courseware helps hospitals provide standardized care and bridge skill gaps at every level in the organization. The healthcare professionals will also become more efficient and empowered when their learning journey progresses with ease and at their convenience. Let us unite to improve healthcare in India by spreading knowledge through technology. MedLearn. Better prepared for better care.
Thank you. Uh, Greetings of the day. I cordially invite all for the webinar session conducted by MedLearn Impulses on developing standards of patient safety and safe medication practices in hospital as a part of Patient Safety Week. Thank you all for taking your time from your busy schedule and joining this webinar. I am Feba Alex from MedLearn. Before we start, we can just have a small brainstorm session. So I want somebody to answer the question. You can use the chat or even you can unmute. When is the World Safety Day and what is the theme for this year, 2022? Can anybody tell me? You can use your chat. Yeah, I can see a few of the hands raised. Yes, you can use the chat also. Yeah, somebody has raised, I can see. And if you can unmute them.
Whoever has raised the hands, I have given the access. You can
Yeah,
unmute
you can
yourself and talk.
unmute and tell. Yes. Yeah, you can unmute yourself. Yeah, it's on 17th September, correct. And very good, very good. It's medication without harm, very good. Medication safety, yes, absolutely correct. Thank you for all your answer. And I saw only one person. Okay, now I saw two people answering. Rest all, you also can put on your chat. So I would request everyone to use the chat option more, because the volume is little high, so we cannot unmute. And you can use, and if in the session, during the session, if you have any doubts, please put up your questions in the chat, so that we can pick up the questions and answer you. So before we going into that, we would like to introduce our speaker of the day, that is Dr. Taranath. To introduce him, Dr. Taranath is a consultant intensivist at Sparsh Hospital, Bangalore. He has been graduated from GSS Medical College, Mysore, and he has done his post-graduation DNB in anesthesiology from Narayana Health. Additionally, he has done IDCCM, that is Indian Diploma of Critical Care Medicine certification, and European Society of Intensive Care certification. His interest, or we say the expertise, lies main on cardiovascular neurocritical care, extracorporeal life support, ARDS, critical care, ultrasound, and hospital emergency system. His strength is like he's very passionate about teaching and has been at the forefront of training doctors and nurses with the latest advances in critical care. Thank you, Dr. Taranath, for joining this session. Welcoming you. Over to you, Doc.
Thank you. Shall we start the session?
Yes.
Sure, doctor.
Yeah. Yeah, thank you, Medlan, for providing this opportunity. It's one of the topics which I wouldn't myself choose to, look at it. But while I went through the data, I found this topic quite interesting and something which we all, as part of healthcare industry, which we all need to focus on. I think the Medlearn's tagline says it all. We need to be better prepared for better care. I think my whole talk will be kind of summarizing and strengthening on the similar lines. So, what is safety? So, as you all know, in our daily routine life, we come across a lot of situations where there are safety measures already in place. Like when you're crossing a road, there's a zebra crossing, or when you're staying in an apartment, there is fire safety alarms being put. When you're traveling across on a flight, I'm sure all of us know how effective these airlines are made, so that safety measures are in place. All these uh, aspects are only looking at one thing, that is preventing harm. So in healthcare industry, there are so many processes which go hand in hand at the same time, but hardly any one of us focuses on preventing harms which can impact outcomes of the patients. So that's why this discipline of patient safety has come into a picture in the last decade or so. So it's a discipline which emerged with the evolving complexity in healthcare systems and the resulting rise of patient harm in healthcare facilities. The whole aim is to prevent and reduce risks, errors, and harm that can occur to your patients during provision of your healthcare. So as I do my daily rounds, I can see nurses who come into their shifts. First thing what they do as they come into their for their work hours is that they'll be holding a paper in their hand and ticking check boxes. So I've always wondered, what do they understand by filling these checklists, and whether it's of any meaning to us, whether it's going to impact healthcare outcomes. So while I went through this whole process of preparing my talk for this session, I understood that how important those checklists are, because one day when your system fails, that's when a particular harm is caused to some patient. So we are all in this phase of learning to make ourselves better, learn better, understand patients problems, and give effective healthcare, so that everyone is happy at the end of the day. So errors do happen, we are all humans, and the whole objective is to make sure that we learn from our mistakes and constantly start improving on this. So next aspect is, why do these harms occur? So I will just go through a scenario. This is a doctor writing a prescription. He's scribbling something and he wants to advise a particular medicine for a patient. That's your nurse, one of our nurses who's understanding the prescription and making up, indenting that particular drug onto the system. And then there's a pharmacy which gets this data, and the pharmacist issues the particular drug, and finally the drug is being injected to the patient. Out of 10, I would say 6 to 7 times there is no problem at all. Most of us know that these are the medications which are routinely used. All the nurses are experts in taking care, and they understand. And 7 on 10, I would say there's no problem at all. I mean, this is a smooth process. But what if the prescription is not understood well by the nurse, and the nurse commits a latent error which impacts this particular patient who receives a wrong medication, or probably she's injected some drug to a patient who's not supposed to get that particular drug. So that's when these harms occur, and that's when the harms can change the outcomes of the patient. So this is the routine process which I was describing. A prescription is placed, which has been transcribed, it has been indented, and it's been dispensed, and finally the patient has got the particular drug. So when the error happens, the most junior staff or the person who's committed the active error is blamed. I mean, that's the routine practice. I generally see this happen even in our workplace, where a particular drug, if not given at the right time, they've been questioned on what's wrong, why it was not given, and it only leads to mental stress for the particular staff. I think the system has to change. We all know to err is human, so the system has to change towards better. And how we can make it better, my talk is going to go through few slides on how patient safety uh, uh, can be improved, and in turn reflect into better outcomes. So this is the data which I want to just show the just want to portray. This was a data from 2020 from the US. So as you can see, the number of patients who died of this is basically a lifetime odds of dying. So out of 12, one would die if there's a COVID-19. In terms of cancer, out of 7, one would die. In terms of heart disease, the lifetime odds of dying is 1 in 6. If you could see, there's hardly uh, numbers which suggest that. I mean, these are alarming numbers, if you ask me. So if you look at motor vehicle crash, it's 1 in 100. So airlines, most of us fear of going onto a aeroplane, because we feel that once on the air, we feel that we might have a crash. What if we crash, and what if we're not there? So basically, if you look at airlines data, it comes to about 1 in 1 million or 1 in 10 million. So the odds of dying on an aeroplane is about 1 in million. So if anyone can unmute yourself and let me know what would be the patient harm, what on a daily basis we can attribute to, if anyone could share what their experience, a rough guess, a wild guess. Anyone around what wanted to take a wild guess on what could be the patient harm?
You can put it in the chat, no issues.
Okay, I think I'll go ahead. So yeah, so this is the WHO data where this is alarming. I mean, I didn't know about this. 1 in 300 chance of a patient being harmed during healthcare. I mean, that's something which is close to uh, somewhere around a gun assault, or you could even say, I mean, it's much safe, much harmful than going on an aeroplane. So what it means is that your aviation or your nuclear industries, the whatever perception of the higher risk is associated, I think we are much more worse than that. I mean, we are living in a very dangerous phase, working, especially with COVID-19 in 2019, 2020. I think the overload on the healthcare was enormous, and I'm sure, I mean, we've committed errors, and which has impacted patient outcomes. So this is a paper from 2016 where, interestingly, aviation has been compared to healthcare. So it was a comparative review of how patient safety can be changed by looking at what the healthcare, what the aviation industry is doing. So there are similar features in both the industries. I mean, both are catering to both are service industries. So if you could, what they found out was that if you could emulate the aviation industry, and by making sure your staff are much more compassionate to their patients, and making them making I mean, if they try to understand the psychological aspects of patients, the safety can be much more improved. Other thing I would want to share from this paper was, they found a lot of cognitive bias while doing procedures. So for example, if I am putting a central line, there is a set protocol which I would follow, and follow the steps. If a nurse has to administer, say, an injection noradrenaline to our ICU patient, there is a certain set of protocols which she needs to follow. So human brain by default is limited by three cognitive limitations. So first one is, you might forget one of the steps, which is probably critical and which can impact your procedure. Second limitation is when you are remembering the step, but you're not doing it properly. Third possibility is you're remembering the step, but you're doing it wrongly completely. So these are the cognitive limitations which all of us definitely would have gone through while we are doing various procedures. So the way to prevent is by doing checklists. So that is why when we put in a central line, or a nurse is trying to administer a particular infusion to a particular patient, I think all of us should go through a checklist. And that is why, after looking at these data, I realized that, when a nurse comes into the ICU and starts checking the defibrillator, how important it is. Because defibrillators, if 9 on 10, they do not cause any problems. I mean, equipments are like, I mean, they work most of the times, but that is one moment when it doesn't work. That's when the problem happens. So all of us have to stick to checking these check boxes, so that uh, our work becomes easier, patient safety is also preserved. So this is an interesting article which I want to share. I don't know how many of you would have seen this movie. It's a Hollywood movie called Sully. So this person is Captain Chesley Sullenberger. He's an advocate of patient safety. What happened? This is a movie shot on I mean, depicts a true happening which happened in 2009. So the Captain Chesley was flying a US airline with 150 passengers in 2009. So because of engine failure, he had to crash land, and he decided to crash land on the Hudson River. So it's an interesting movie, and if none of you have watched it, I would recommend this as a must-watch movie. So when he crashed land, he became a media hero immediately, because 150 people survived, none of them died. But what happened later was, he had to undergo a trial by agencies, because they felt that this could have been averted, and he should have gone and landed in a safe airbase. But when they went through simulations later, they found out that this was the only way the captain could have landed and made sure that all his passengers, 150 of them, could survive. So Captain Chesley was invited to give a keynote address in 2012 at a conference. And what he found was that, looking at the WHO data, that's 300 harms which can be caused, uh, he felt that if that could simulate in an aeroplane scenario, there would be at least 3 crashes every day. And these three crashes would mean that the aviation industry would stop. There would not be any aeroplanes anymore, and none of us would fly. So that's where the aviation industry is much advanced. You can even look at F1 race where the pit shop, they change the tire, or they make sure the car is safe for the F1 driver to go through. So these are all happening because there are so many precautions taken place. They learn through their errors, they learn through their mistakes, and there are checklists, thousands of checklists which they go through. I'm sure in our practice there are agencies which look into it, NABH or JCI and other. I'm sure most of them, most of us, we feel, oh, this is adding a lot of paperwork to our routine practice. But yeah, but there is a meaning to it, and I understood about this patient safety being such a core discipline. I think all our focus in at least the next decade should be to try to avert such harms. So what happens generally, as I said, the junior staff is blamed for that particular active error. I don't think that should happen. There should be communication between the team members, be it the nurses and the doctors or the administration. We need to find out why this particular wrong medication or the wrong dose or wrong patient has been harmed, because transparency is going to be very critical in addressing these core problems. And only through communication, I think there is going to be a solution, and we can improve our patient safety margins. So let's look at data. What is the burden? I mean, why are we worried about all these problems? What's the burden? So the occurrence of adverse events due to unsafe care is likely one of the 10 leading causes of death and disability across the world. See, we talk about TB, we talk about malaria, we talk about dengue, we talk about COVID-19 in the last couple of years. But this is alarming. I mean, it's one of the 10 leading causes of death. This is the WHO data, so it has to be real. I mean, we need to really push our limits. Look at this. One in every 10 patients is harmed while receiving hospital care. Now, harm can be anything. I'll explain to you what harm could be, but this is again an alarming figure. One in every 10 patient it could be one of us. So out of this 1 in 10, at least 50% of them are preventable. So preventable is the key word here. So we can stop that five patients to, we can, make sure that the 1 in 10 has to become 1 in 100 at some point of time, because it cannot be so common. Look at this, the next data. 4 out of every 10 patients who are in the primary or outpatient healthcare are harmed. So this is what during transit in the PHCs or in tertiary, in primary health centers, or during transport, or during ambulance visits. So this is again an alarming figure. So we don't have Indian data, but globally WHO has found out that lots of millions and billions of dollars are wasted and spent on improving patient safety. Say, for example, a harm is caused. That harm is impacted the patient's outcome in such a way that the patient has to dwell more days in the ICU or in the hospital, and that in turn leads to expenditure. So 134 million adverse events occur in hospitals in LMICs, that is low and middle income countries, due to unsafe care, which is resulting in about 2.6 million deaths. So this is the burden of harm. That's why we are talking about it. That's why we have WHO looking at this. And yeah, these are the kind of harms which can occur in a normal hospital scenario. We can call it medication errors. That is something to do with a particular medicine prescription, administration error, or whatever involved with the particular drugs. Hospital, healthcare associated infections is a next important aspect which all of us are already focusing on. Antibiotic resistance is a problem. So then there are procedures which are done in an unsafe way. There are injection practices which go unchecked. And about 5% of the problems are due to diagnostic errors, where you're not able to diagnose well because probably you don't have the expertise, or probably you don't have the equipment. So I mean, globally, these are issues. At our level, probably when you're working in a tertiary center, you might not find all these problems as really important, but in in globally, when you look at the larger picture, I think these become very important. Then there are unsafe transfusion practices, radiation errors, issues with sepsis and DVT prophylaxis. These are all patient safety scenarios. So what was the WHO response? So WHO decided to adopt a resolution in 2019. So they found patient safety is going to be the next most important aspect which they need to look into, and that's why they launched this World Patient Safety Day in 2019, which is being observed annually on every 17th of September. So the first World Patient Safety Day was observed on in 2019. The theme that time was global, I mean, making patient safety a global health priority. So the slogan that time was "Speak up for patient safety." So basically, it tried to bring out a cultural change in the healthcare industry. So we started focusing basically on why patient safety is important. We looked at the burden, we looked at the damage, we looked at what we can what we are foreseeing in the next decade or so, and that's why WHO made it important, a priority, that all of us speak about patient safety as we speak about getting a particular diagnosis, getting a particular treatment, I mean, making someone survive. So at the same time, patient safety needs to be important. In 2020, the theme was health worker safety. So 2020 and 2021 were the COVID-19 years, where all of us went through a crisis globally, and I mean, at our own levels, be it in a nursing home or in a hospital, everyone was overwhelmed with work because the number of patients had drastically increased. So that's when the slogan was "Safe healthcare workers leads to safe patients." So unless the healthcare workers are safe, obviously they cannot make sure that the patients are safe. But and that's why they started, the slogan also said that you need to speak up for your own safety, speak up about your own mental stability, whether you're ready to work, whether you're fine today. All these were aspects which they looked into as and brought it as a theme in 2020. In 2021, they looked at stillbirths, maternal deaths, and peripartum deaths, and that's why the theme that time was last year was "Safe and Respective Maternal and Newborn Care." The slogan that was "Act now for safe and respective childbirth." So coming to 2022, that's last week, we celebrated the World Patient Safety Day on 17th September. This year's theme is built on an existing global patient safety challenge. So if you are not aware, WHO launched their first global patient safety challenge in 2005, where they looked at clean hands. So where they looked at hand hygiene. I think most of us now, especially with COVID coming in, we've all started using hand sanitizers much more frequently. I mean, even the layman is they're using chlorhexidine sprays for after every procedure, or you're shaking hands, you're using the hand rubs. So 2005 was the year when they launched their first global challenge, where they looked at hand hygiene particularly. And 2008, they looked at surgical safety checklist. So in 2008, they came up with this protocol where a patient goes into a surgery, there is a timeout method, and there's a checklist which they looked at. So first and second global patient safety challenges were in 2005, 2008. The third challenge was recognized as medication without harm in 2017. So the medication harm accounts for about 50% of the overall preventable harm in medical care. And that's why WHO found that this should be the next most important thing. And the goal over the next 5 years is to reduce this harm by about 50%. So all of us learn this. I mean, being a nurse or a healthcare worker or a doctor, we all go through this principle in our life. First thing is we should not cause any harm. So, I mean, WHO has recognized patient safety as a global health patient safety challenge, and all the principles are based on this foundation that we should not cause any harm. This is the strategic framework what they've designed for advocating medications without harm. So there are mainly four domains: healthcare professionals, medicine, systems and practice of medications, and patients and public, which is in turn divided into 16 subdomains. So I'll not go into the theory of this, but what you need to understand, there are three main key action areas what they have highlighted. First is the high risk situations. These are situations wherein your patient has got uh, a particular problem where you need to make sure that whatever molecules, whatever drugs you're using, they are definitely high risk medications, and you need to be doubly sure or confident that you're not causing any harm. So this is an acronym which is being used for all these high risk alert drugs, high alert drugs, anti-infectives, potassium and other electrolytes, insulin, narcotics, chemotherapeutic agents, immunosuppressive agents, heparin. So this is just if you ask me, I think all the medications, including a pantoprazole or an ondansetron, they need to they need to be administered only if there is a need. So that is one key area where we need to focus on. Whenever there's a patient who's requiring these kind of drugs, we need to be double alert. Second aspect is drug interactions. So this is one aspect which even doctors don't look into it on a daily basis. The reason is, say for example, a cardiologist comes in and he advises a particular set of medications. Then there's a nephrologist or a pulmonologist who will come and write his own medications. Hardly anyone looks at this aspect, whether this particular drug can be given with another molecule. So because I mean, it's humanly impossible to know everything in literature, but we should make sure that those drug interactions do not cause any harm. So when we look at polypharmacy, the polypharmacy is defined by anyone who takes more than 5 medications at a time. So we should also look at this aspect, drug interactions, and that's one aspect which clinicians should also be much more vigilant about. Third important key action area is transitions of care. So when there is a patient being shifted from, say, OPD to IP, getting admitted to the ICU, or someone who's getting transferred from one ICU from some other hospital to another hospital, we do not communicate well. We miss out on information, we miss out on allergies, we miss out on important data regarding the patient, and that's where the whole exercise repeats. For example, a patient has got certain medication which has not helped him in another place. What's the point administering the same medication or causing more harm by giving the same medication once again? So we all fail to communicate well, write good discharge summaries. We all fail to understand patients issues, and when they don't have an option to understand by themselves whether 10 medications are required, it's our job to make them understand that this is what is required for him. So WHO has looked at three key action areas this year as part of medication without harm, and the three action areas are high risk situations, transitions of care, and polypharmacy. So this is what we normally do, and but hardly each one of us focuses on the details. So these are the 5 moments of for medication safety. So while you're starting a medication, try to understand whether this patient needs this medication. If so, is this the right one, and is this the right patient? Second thing is, if the patient himself is taking the medication, he should also know whether what time he should be taking with can I take food now, and other aspects of the medication, what are the side effects or what are the adverse reactions. So taking the medication, someone should know whether this particular medication needs to be given. If you're adding another medication, you should also know whether this particular medication can be added with another molecule. Is there any drug-drug interaction? And someone also has to review. I mean, when you are adding particular medications every day, you need to review your charts and find out whether this particular medication is making any help, helping any patient, helping a patient or not. If not, whether it can be stopped. So these are the 5 moments where each one of us, being a nurse or a doctor or a clinician, should focus on and ask ourselves daily whether this your patient requires this medication. If so, is this the right dose? And so on. Review whether this drug can be given with other molecules. And at the same time, if it's antibiotics especially, or steroids for that matter, we need to make sure that there is a plan to stop. There are certain other medications like pantoprazole. Every discharge summary will have a pantoprazole which will be running through their life. I don't think that such a medication is required at all. And this is the next aspect where WHO has, as part of the this year's theme, no check and ask. I think this is important both for healthcare providers as well as patients. They need to know what their medicine is. They need to check what the dose is and what time they have to take, and whether, if they have to take, ask your clinician whether they need to continue it. So coming to next few slides, we'll be focusing on what kind of harms medications cause. So the first aspect is to understand what is a medication error. So medication error is defined as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. This is theory. If you ask me, say for example, you're starting a normal saline drip for a patient. If you've not unclamped the patient's IV cannula, we put a clamp to occlude. If you do not unclamp it, that's an error. If you have given the wrong medication to another patient, that's an error. If you've not identified your right patient, that's an error. If you, instead of noradrenaline, you are giving some other medication, that's an error. So any medication or any error which can be preventable by double checking is going to definitely change your patient's outcome. So all these errors are most of the time preventable, and our focus should be on stopping these errors from happening. So next important thing is adverse drug reaction. So adverse drug reaction, commonly referred to as side effect, this is a response which is noxious, unintended, undesired, but it occurs in most of the patients normally, and the dose what you're giving or the drug what you're giving is the right one. So basically these are known problems which can happen with a particular drug, and it is generally not preventable. So medical errors are not part of this because it is a known negative outcome of a drug. So we need not be worried, but we need to be cautious about understanding whether an ADR has happened. If so, what is the next measure? What could you do to lessen the problem, or what you could do to treat the problem? Next important aspect is ADE, which is not same as ADR. ADE is adverse drug event, which is definitely an unfavorable and unintended response to a drug, whether or not considered related to the product. So here you cannot 100% say that is because of this drug, this particular problem has happened, but this is a adverse event which is not intended, and most of the times it can be prevented. So this is a graph which depicts medication errors which are much more common than ADRs and ADEs, and 25% of the ADEs are caused by medication errors. So as I said, medication errors are most often preventable. So our focus should be on reducing this aspect, that is preventing adverse drug events because of medication errors. ADRs, as I said, are generally not preventable. So when do these errors happen? In what phase of a patient's course during the stay these errors happen? So it can happen at any step along the pathway that begins when a clinician prescribes a medication and ends when the patient receives the medication. So it can happen when you're ordering or prescribing this medication. It can happen while the doctor or the clinician is documenting this. It can happen while the nurse is trying to understand what the medication is about. It can happen at dispensing level or when the patient is getting that particular drug. And monitoring, as I said, it is what a clinician should do. So what I mean by monitoring is, say a particular patient has got a chronic kidney disease or a liver failure or such aspects. So certain medications cannot be given in their usual dose, so you need to monitor, you need to understand that you need to modify the doses. So ordering and prescribing, that's where your 50% of the medication harms occur. And most of our healthcare workers, nurses and pharmacists are able to identify 30 to 70% of these errors. So this number has to decrease by giving more attention to all your prescriptions and making sure administration happens correctly. So next, coming on to the next aspect, which is types of errors. So types of errors, the most common one is the prescribing error. So we are the most important people to blame here, the doctors. So handwriting not legible. I mean, you write in continuous cursive writing, and the nurse doesn't understand what the prescription is, and that's one major problem which is the, it leads to a lot of other problems. So other thing is omission. So a particular drug is written but the nurse doesn't want to follow it because she's busy with some other patients. So in Indian scenario where our nurse patient ratios are less, so this is also an important aspect which can lead to medication errors. Wrong time, again, because a particular nurse is busy with a couple of patients, and maybe there's a code blue in some other area, and your patient is uh, not getting the right time medication, so that also leads to medication error. Unauthorized drugs, this is not a major problem. Improper dose, so calculations. So most of us, when we write a particular drug, we write in mgs or grams or micrograms, and it's up to the nurse to calculate the right dose. If we, usually with respect to IV medications, loading infusions, this becomes a major issue. So especially in pediatric age group, so it's a major challenge. So giving wrong doses, that is a type of a medication error. Wrong prescription itself, or a wrong dose preparation, instead of diluting it in normal saline, if someone is supposed to dilute in someone dilutes it in 5D or uses some other agent, that becomes an error. Administration errors are also most common after prescription errors, where you would have connected this drip to a patient, but unfortunately the patient is agitated and the drip set is disconnected, so leads to patient not getting the particular drug. Monitoring errors, I have already described that. Compliance, yeah. So when we write particular especially antihypertensives, there are 3 antihypertensives charted for a patient. So uh, sometimes what happens is the timings are same, so each one is given at the same time. So and sometimes when the blood pressure is not stable, you try to change the time, and then the medications are not getting on time. It happens even with the glycemic levels. You give insulin sometimes and the sugar drops, and you don't give insulin, the sugar climbs. So these are all issues which leads to medication errors. This is an example of a prescription. So this is a digoxin. A doctor has written, he wants to write 0.5 mg, but he's written 5 mg. Obviously it leads to a medication error. So we clinicians, we need to focus on how and when we write our prescriptions, whether we are giving the particular drug for the right patient, whether this patient deserves this particular molecule, and if so, are there any contraindications. So as I said, calculations is the major challenge for especially in pediatric age group. If you rightly do so, well and good. If you're not sure whether you calculate the right dose, use a calculator. Do not stress yourselves. This is a common scenario where a nurse is handling, I mean, this is heroic effort if you ask me. I mean, I should congratulate each one of us who takes care of such complexities. But it's a challenge. I mean, you look at the number of infusions going to this patient. Obviously there's huge margin for error here, but our focus, our priority is making sure that we do not cause any harm to this patient. So why do these errors happen? I mean, why does it happen everywhere? Does it happen in busy centers? Does it happen in nursing homes? So high volume definitely leads to less manpower, and at the same time, it leads to more errors. So the whole objective is, when your patient load is going up, you should obviously, the management obviously should look at improving your manpower strength as well. Poor handwriting, can't say much about it. I have a poor handwriting myself. Inexperienced staff. I would put it as, if all the junior staff, when they join in, they need to be given a time frame to understand what the dynamics in a particular healthcare, in a ward, on an ICU, and don't give them too many responsibilities at the same time. Challenging population is something which we cannot complain much about. Lack of policy enforcement. So there are rules, like NABH has got their own rules, JCI has got their own rules, but uh, what's the point of having a policy without enforcing or making sure that it is being followed? So that's one of the problems where medication errors happen. Lack of appropriate monitoring, medically complex patients. So these are also other risk factors where harms, I mean, the number of harms can go up. Requiring calculations, environmental factors. Most important, I always tell my nurses, communicate, talk to your colleague, talk to doctors, talk to your people around, talk to your patient, because that's the only way you can understand what's going on. And obviously all of us go through stress, all of us have our own problems, so we can't complain much about it. So what do you do to prevent? I think we're running out of time, so I'll quickly go through this. Yeah, what do we do to prevent? Prescriptions have to be clear. So when I say clear, most of us, at least on the drug charts, we need to be making sure that we all write in capital letters, bold letters, use only one sort of ballpoint pen or whatever, blue ink, or I mean, there are set protocols each hospital follows. So all of us should comply and make sure that the prescription is well read by anyone around. When the nurse or someone else is healthcare workers reading the prescription, spend a couple of seconds extra on understanding what the prescription is all about, whether your patient needs this particular medication. Sometimes doctor would have written a particular medication in the wrong chart, so try to understand whether this is the right patient. Consider the patient's age. There are certain medications in the extremes of age, be it pediatric or elderly. There are certain contraindications which most of us with practice we are well aware of. But if due to certain reasons we might lose our focus, and it's always better to understand whether this patient needs this. Look at other kidney, liver functions, and tell your clinician to provide directions whether it can be diluted in particular solution or not, what is the amount, what is the timing, or what time it has to be given, over how long. So all these are important things which a clinician should make sure he writes in his prescription. Careful use of abbreviations. So yeah, I have a slide on this. So we need to make sure our handwritings are quite neat and legible. Duration of treatment, especially with respect to antibiotics, I think this is one aspect which we need to focus on. We have to restrict the number of days for a particular antibiotic. There's no point keeping the patient on 20 days of antibiotics for no reason. Remain alert for high risk medications. Add instructions wherever possible. adopt a reporting system. So we all should understand that, as from the beginning of my talk, I said that the blame has to be on the system and not a particular person. So we need to be very transparent and clear and vocal about our problems, why this error happened, and try to adopt a reporting system as well in the hospital where this kind of errors do not repeat again. So my ultimate strategy for all these problems is digitalization. Hardly less than 1% of our Indian hospitals are digitized at this point of time. So the advantages of digital prescriptions are enormous. Look at it. I mean, uh, when you're say, I mean, when you're typing a particular molecule, if you're going writing the wrong spelling, it obviously doesn't give you that particular molecule. If you're once you put an indent on the system that you want to say indent for injection pantoprazole, there's an alert if it is contraindicated, or if this particular patient doesn't qualify to receive that. And reordering or refilling, so tomorrow you want to repeat the molecule, it becomes easy by digitization. And you can also make your prescriptions more efficient. There's no confusion. All your nurses know that what is being ordered is I mean, very clear. I mean, it is a particular molecule. Say you want to give ecosprin for this patient will get ecosprin only. It cannot be anything else. It obviously impacts patient's outcome. You can prevent readmissions, saves a lot of money. Digitizing for the hospital might cost a bit, but over the long run, I think hospitals do benefit with improving their services. And obviously, because it's electronic, you have a data, you can audit your prescriptions. The next most important person I feel, especially in ICU, is a pharmacist, clinical pharmacist. The more they join the daily rounds, the more they look at your ICU charts, more prescription errors are prevented. So finally, look at this: the 5 rights were to prevent medication errors: right drug, right patient, right dose, right route, right time. If you follow all these 5 principles, I think half of your job is done. So this is the slide on prescription errors. Look at this most important one, QD. Someone wants to say it's daily. It's mistaken for QID. Instead of that, so it becomes Fortali. So it has to be once daily. Look at using of decimal points. So someone wants to write 0.25 mg. He misses that 0 point, and someone interprets as 25 mg. So these are huge errors. A nurse wants to start a drip at 2000 drops per minute, ends up giving 20 drops per minute. So to sum it up, it's not his or her or someone else's fault. It's our fault. We need to understand to put systems in place. Every fault, as the Captain Sullenberger in his in his report said, every problem or every harm caused has a pattern to it. So try to understand the pattern, try to understand why the system has failed, and at the same time introduce new protocols or new safety measures. Maybe it may add uh, additional paperwork, but use technology, use mobile apps, use other platforms which can prevent such errors. So catch the error before the effect. Yeah, this is a nurse who wants to give a particular medication. She doesn't know whether this is the right route and she decides to give it IM. So do not assume things when you're handling medications. Try to understand that if you're not understood, it's always good to ask. Communicate to your colleague, communicate to your clinician, ask him or her whether this has to be given IV. I do not know how to give it. There's no harm in asking questions. There's no, because the wrongdoing is much more harmful. To sum it up, this is again, I had to put this slide to make you all understand. We are all, what we have right now, quite frankly, in healthcare are islands. This is words by Captain Sullenberg himself. Visible islands of excellence in a sea of invisible failures, with risk lurking just below the waterline. We need to widen those islands of excellence. So We need to make sure we are at a better place tomorrow. With MedLearn, I'm sure we will be better prepared in as we advance. And finally, it's always a team effort. It's always a teamwork which helps. No single person can change a patient's outcome. Thank you. I'm opening this for discussion now.
Thank you, Dr. Taranath, for this insightful session. As a healthcare worker, I do believe that we should be
Eva, you're on mute.
You're muted.
Can you hear me now?
Yeah.
Yes.
Yeah.
Okay, thank you, Dr. Taranath, for this insightful session. So as a healthcare worker, our aim should be to promote safe medication practices to prevent medication error and reduce medication-related harms. By this, I would request everyone to put up their questions in the chat. If you have any questions, you can put up in the chat. By then, we would like you to take your 10 minutes of time to summarize on the certain things. Like, as we have heard from Dr. Taranath, that we have to look out for some of the practices to achieve a safe patient safety. So how do you think when we focus more on having a best patient outcome, two things comes in the mind is one is quality care and second is best clinical outcomes. So how can we achieve it? Once Dr. Taranath has mentioned that we can achieve it through NABH. Okay, so NABH helps us to achieve this. MedLearn here is, yeah, sorry, somebody has asked the question. Okay.
Are there any good, shall I take that question?
Yes, yes, sure, doctor.
Are there any good real-time IPD hospital medication reminder dashboards for nurses to ensure that they give the right medication at the right time? So that's an interesting thought, Dr. Matthew. So I've always wondered if each patient bed can have, a sort of a, in malls you have these TVs. So similar kind of things where there is a constant data which is flowing next to your monitor and reminding each allocated staff what medication has to be given at what time. Obviously it adds on to the hospital costs, but that's an interesting thing which we need to look at. Other thing what I try to advocate, in my ICU I try to advocate is at some point of time each one, if there are say 10 nurses in on the floor, there should be a timeout where all the 10 of them discuss amongst each other whether the particular all the medications have come from the pharmacy and all the patients have got their medications at 8 o'clock or 9 o'clock or whatever. So that brings out a certain culture where such medications do not get missed.
Thank you, Dr. Taranath.
You can continue, yeah.
Yeah. Is there any more questions to go in? Yeah. Can you put it in the chat, the question, if you're not able to unmute it? Okay. Are we expecting any more questions over here? Do you have any training program in MedLearn? So what I was talking is about NABH. So what is NABH? I'll just give a short what I was talking about. So NABH is National Accreditation Board for Hospitals, and it consisted of Board of Quality Council of India set up to establish and operate accreditation program for healthcare organization. As everybody know, it has 10 chapters, 100 standards, 650 one objective elements, and each accreditation standard is a statement of an expectation or requirement which makes it possible to deliver quality care. Objective elements are subcomponents of standards. So in this, we have 10 chapters. Each chapter is divided into patient-centered and organization-centered. And in that, we have five elements under that. So how does MedLearn helps you? So it's a good news that MedLearn has a certification program for NABH 5th edition, and we have it in a form of e-learning modules, which is designed to help you propel your fifth edition accreditations have been reviewed and certified by the International Society of Quality in Healthcare for a period of 4 years with effect from April 2020. The healthcare organization will start to adopt and migrate to this fifth edition standards with immediate effect. And I believe that we are already doing it. So MedLearn offers the certification program that covers the entire 10 chapters, the 100 standards, 651 objective elements to provide the knowledge and insight which is required to ensure that compliance with the latest healthcare practices has been obtained. So the key elements of the program which we are providing as a MedLearners are comprehensive coverage of entire NABH 5th edition, detailed understanding of each standards for easy implementation in your routine practices. We have case scenarios with practical tips on day-to-day challenges encountered by the healthcare staffs, real-life insights from NABH assessors and healthcare quality managers who handle the challenges regularly. Learn through engaging self-assessment videos and multimedia-rich content, which will provide you insight about NABH. And this has 60 hours of mobile compatibility learning modules at your convenience. So that means you don't have to you don't need a computer or a laptop. You can access it through your mobiles, which is, you can take it anywhere, wherever you go. So these are the modules which is a part of each chapter. So you have all the modules covered under each headings and chapters. Yeah. So what else we do? So we also help audit preparedness and scoring system. This course is also designed to help the organization to systematically monitor the systems and process to ensure effective operational measures are there in place. The stepwise understanding towards documentation, implementation, and monitoring with self-assessment to understand where we are. The scoring system and accreditation decision criteria and accreditation cycle is also brief in the course for completeness. The highlights, like I already described, of the NABH edition, key aspects for how to get prepared for NABH. It also explain an organization that what are the compliance implementation you should take to get it prepared for NABH. Process of self-assessment, audit preparedness, define the new audit score system in NABH. Like we keep on updating what all are the standards which comes under NABH. Defines the overall compliance rate for accreditation for an organization. So who all can take course? Hospital administrators can take up this course, quality managers can do, nurses can do, nursing students can do, physician can do, allied health professionals can do up this course. So I still remember when I was a student, I always was keen to look up into NABH. So I personally always search in Google, like what are the courses available for NABH, and if I have to go for an NABH assessor course, or what is the medium. So here we have the entire courses for you. Believe me, if you do this course, there are lot of opportunity in the hospital to enter up into the NABH committees, put up your stand as a senior nurse or maybe as a senior doctor, improvise your own hospital to get the NABH standards. And you can avail this course for 15,000 and a training certificate. You will be getting a training certificate on completion of this NABH 5th edition. And the good news is this course will be valid for you for 1 year. Maybe you would be completing this course for 2 to 3 months in, but still you can avail this course module to 1 year. And this is a certificate you will be receiving it once you finish the course, and it will be automated certificate. Then and there you can avail it. And you can contact us. We have given you the contact number. And I think there is some more surprise for you. That is, you can now avail this offer as just 7,500 because we have a 50% offer valid till September. So I'll open this page. You can just note down the contact number, or maybe you can go to our website and avail it. And thank you all for your patient listening. And this is the contact number where you can go on, and you can also check on the store medlearn.com for the further description of the content or the courses. Hope so I was not too fast, and sorry for the delay and the interruption which has been caused in between. And we had a very wonderful crowd, and also we had a lot of interaction. And if anything is there, in case you have any questions left out for Dr. Taranath, you can just pop up the question here. The doctor will be ready to answer for that. Or anything you have towards Medlearn, please contact us. We will be all ready to clear your doubt. Yes, there's a question. Does the certification course makes us NABH assessors? This is a very good question. So this course is basically works as not for the NABH assessors, because it is an entirely different course which is being conducted by the NABH, and it has certain criterias to fulfill. And you will be getting the course as an assessor's certification. But this course acts as like a bridge one, where you can take this course and you yourself will be a TOT, that is a trainer of trainers in your organization, and you will be able to improvise the thing in your organization. So it doesn't replicate the NABH assessor course. So NABH certification program eligible. Okay. Yes. Everybody is, as I showed, anybody can take up this course, even though if you are from a background of BAMS. You can contact us for the further details. Thank you all. Thank you. If we do not have any more questions to be left, thank you. So we have posted the contact number in the chat as well. As hope you all enjoyed the session. Thank you all.
Thank you, Medlearn.
Thank you, Dr. Taranath.